What I'd like to do is start by having you take a journey with me into the intensive care unit, because this is usually where I would start out my day. I would be coming on service. Critical care physicians now pretty much work like emergency physicians, and they might be on shift work for a week or so and then have some time off. But as I go in, one of the nurses quite commonly would grab me by the arm and say, you know that there's a patient in bed 7. She's been on the ventilator now for 4 weeks. Her organs are all starting to fail, and the family is not willing to let her go. You really need to go in and start working with that family. That patient needs to go to heaven. So this is the kind of dilemma that we get into in the intensive care unit, where the patient and family have never had a discussion about the end of their life, or what they might wish, what they might tell somebody, and of course they're in a situation where they can't participate in the conversation, so we have to use what we call substituted judgment and shared decision making. And this brings in our own values and individual values, but what we really don't know is what your values are. So there's a lot of denial about this. Things are changing, but I think denial is quite common. William Saroyan said, everybody has got to die, but I leave an exception will be made in my case. And that's fine. I think denial is healthy. Obviously, you folks aren't in denial because you're here tonight. But a quick maybe show of hands, how many of you have some kind of advance directive? Pretty good. Anybody here have a POLST form? I'll go into that if you don't. So if you do, so we'll introduce and discuss that a little bit later on. And then when we get to the end of the talk, I'm going to show a short video clip about an ICU. It's kind of a rap video by Z-Dog MD. So that will be wrapping it together at the end. World mortality rate. Somebody asked me if I updated this slide. I don't think I need to. This is from The Onion. Wonderful magazine. Kind of reminds us that we do have the end coming at some point. And you know, we only die once. We pay taxes every year, but it's a one-time event. Hopefully it's a one-time event. So how do we begin to think about it? How do we imagine it? The younger we are, the more difficult it is. I gave this talk at the UW Law School twice, and none of the young want-to-be attorneys in the class had any will or advance directive, none of the above. So it's something that comes upon you as you age, and your wishes and hopes become clearer as we do age. The Conversation Project, if you had to just go to one site on the web, I would go to Ellen Goodman's Conversation Project. She's a Pulitzer Prize winning author, and her mother had what I think she would describe as a bad death, prolonged unnecessary suffering, which was not well managed. So she put together a project where you can go in and you can download a starter kit, how to talk to your family, how to have the meaningful discussions, what are your values, what are your hopes, what are your wishes. So that's an important one to think about. There are some local things happening. Let's have dinner and talk about death. This started out at the University of Washington, and it would be in a smaller venue like this where we could sit around and actually have a discussion. There are death cafes all around the world now. These are just meetup places that you can find on the web. I know there's been one in Capitol Hill, one in the North End, where people get together and talk about the end of life, what it's the meaning for them, what are their hopes, wishes, fears, etc. Medicine is finally getting into this. Dying in America, the Institute of Medicine has an extensive report that you can find online. And by the way, I do have a handout sheet with all these websites I'm mentioning that you can pick up if you haven't. And interestingly, the AMA Journal came out with the January 19th issue, which is entirely about dying and death and the issues that surround that. All the issues are discussed, even death with dignity, pro and con arguments, statistics on where we die. I did mention intensive care units, and this is one of the problems in the United States, is in that last month of life, we are the world leaders in use of intensive care units and use of chemotherapy in the last months of life. So we are still far too aggressive. One area we're better at is dying at home and use of hospice. So these things kind of counterbalance each other. Some of us prefer to die at home and find hospice. Others may wind up in intensive care unit, maybe prolong the dying process rather than having a beneficial outcome. This is Ezekiel Emanuel, brother of Rahm Emanuel, who you're probably more familiar with. He's an ethicist and oncologist at the University of Pennsylvania. He has a featured article in this issue of The Atlantic, which was devoted to aging. And he said he wanted to die at 75. He felt we ought to get out of the way, that he wouldn't even take an antibiotic after he's 75. And being older than that, I take umbrage to that statement. But we are facing a huge wave of baby boomers aging. It's called the silver tsunami, and we're in the middle of it. The 60-some-year-olds are now aging into Medicare, and as a society, unfortunately, we're very ill prepared to handle this. So, conversations. I made this plural because this isn't a one-time event. This is a repeated kind of conversation with your loved ones, your decision makers, your physicians, your other caregivers. So what surrounds that when you start having these conversations? You have hopes, you have fears. You do have rights to have these conversations and have them documented. Under the new Medicare law starting January, your physician has a right to bill for a visit when you want to come in and discuss your advance directives. So there's a lot going on in this area. Our decisions really vary with our cultural background, our spiritual beliefs. It's a very individual thing. What you might want, your neighbor might not want. And it can be quite surprising if you go through a value sheet and begin to look at that. So I'm going to tell you some stories here that illustrate some of the patients that I ran into and some of the ways I would think and how decisions were made. I'll call this fellow Joe. He was a patient with emphysema who was not doing well. He had several hospital admissions in the past year, but he still lived independently out on Vashon Island, and he'd come all the way over to see me. But he knew he was not going to continue to do well. He didn't want to go on oxygen, although he had started it. But he said, you know, life is just not doing well. Doc, I want to take you out to lunch. He was a kind of a super salesman guy, and I was afraid he was going to try to sell me something. And in a way he was trying to sell me or talk to me about the way he wanted to die. He did not want to suffer at the end. He said, it's like I'm a fish out of water. I just can't fathom the idea of not being able to breathe. You've got to help me at the end. And I said, well, let me explain what we can do, and it's perfectly acceptable medically. I can give you morphine or a similar type drug. It would take away your shortness of breath. It would give you euphoria, make you sleepy, and give you a sense of peace. He said, well, that's exactly what I would want. I said, there's a downside. It may speed up your demise by a matter of hours or even days. Medicine is what we call the dual effect. Your intent is to relieve suffering. This is palliative care. But a side effect of that can actually be to speed up somebody's demise. And he said, I'm not worried about that. Another few hours, a few days is not really the issue. I said, well, talk it over with your sons. Make sure they're on board. And he did, and got back to me and said the family was in agreement. And then he was back to his usual living, but a couple months later, I was called from the emergency room that Joe was there, just gasping for breath. They wanted to put him in the intensive care unit. I said, hold him there. I'm going to come in and see him. So I did, and he looked me right in the eye and said, remember what we talked about? So I reviewed the treatment plan with him. I did not admit him to the ICU. I put him on a medical unit. Fortunately, there were two very experienced nurses who were willing to go along with the plan to give him small boluses of morphine and titrate his care so that he was sleepy, not short of breath, and comfortable. And he died that night at about 2:30 in the morning. Not too long later, I got a beautiful note from the son saying, "Dad went exactly the way he wanted. If he could come back, he would shake your hand." So what if I hadn't been there, though? This is what worries me. You know, were his wishes documented? Were they really known? Would they be respected by the other caregivers? Did he have an advocate with him that could look the doctors in the eye and said, "No, he doesn't want to go to the ICU. He wants this." So this is why these conversations are so important, because when we're admitted to hospitals now, we're generally cared for by strangers. There'll be the hospitalist on call or the ICU doctor on call, and your family physician or internist may not even visit the hospital much anymore. So it's kind of up to us and our caregivers to be really strong advocates. So sometimes families don't agree. This was my dad. He was 94 years old in a nursing home in Western Pennsylvania, lovely little town. And he had been slipping for several years, had been in assisted care for a while, and then moved near my sister in more full nursing home type care. My sister called kind of really concerned that Dad wasn't eating. And I said, well, that kind of happens sometimes when you're up in your 90s. But you got to talk to the doctor, or the doctor talked her into getting a whole body CAT scan, which I felt was totally unnecessary. They found a 1 centimeter spot on a kidney, and my sister said, shouldn't it be biopsied? And I said, absolutely not. It can cause a lot more harm than benefit. If it is a small cancer, it's not causing any of his symptoms. So anyway, they backed off. Then he quit drinking, and they gave him good mouth care, little sips if he ever wanted it. But he just gradually slipped into coma. I could stay on a cot at his bedside at night. They did give him small doses of morphine for comfort, and he was able to just die peacefully. But one of my relatives was really against that. He said, so you're just going to take those old people out there and let them die? You know, he kind of thought of the death panel concept. And I said, no, we were carrying out Dad's wishes. He did not want intervention. He did not want high tech. He did not want to be kept alive unnecessarily. So that willingness to let go. If you got to be just one book, I would read Atul Grundy's book, probably a lot of you have, called Being Mortal. And he also wrote an article, I think it was in the New Yorker, called Letting Go. So how do we let go at the end? You have to shift from that curative mindset to the palliative or comfort care mindset, and that's not always easy to do. Almost 2/3 of us are unable to participate in the conversation at the end. In our last few weeks of life, we're just too sick to do that. So what can we do about that? If you're going to do just one document, I would do your durable power of attorney for healthcare, but actually I would do more than that. But if this is probably the most important one for most of us that aren't terminally ill. This power of attorney is a very special kind of individual. It's got to be somebody that is a strong advocate. They've got to be available. They've got to be able to stand up to other family members. It doesn't have to be a family member. It can be anybody you choose. Every once in a while, people can't find anybody. And there is a Washington State Advocacy Association that can actually become your advocate and help out, and that's on the handout as well. And that person really needs available. A daughter in Japan might be great, but unless they can come to the bedside and really participate, it's very, very difficult to be that strong advocate. So who speaks for you in Washington State? Let's see if my pointer works here. Of course, if you have a legal guardian appointed, that person has medical powers for you. Durable power of attorney trumps anybody else in the family. That person is the one that can make medical decisions for you. So what if you don't have a durable power of attorney for health care? Then it becomes your spouse or your registered domestic partner. But what if you don't have a spouse? Well, then under state law, it goes to your children. And under state law, all of your children have to agree. So if any of you have children, do they always agree? So I know mine don't. So anyway, that's why it's important. If you want to make a child your durable power of attorney, that's fine, but then select an alternate and even a second alternate if somebody isn't available. And then if there's no kids, it goes to the parents. And then sometimes it has to go to the doctors using their best judgment until we can locate somebody. So sometimes we don't know in the ICU. Okay, I'll repeat the question. But in general, I'd like to hold the question till the end, but that's a good one. What happens if there's no family agreement? At that point, we are stuck. We continue full treatment. The default in medicine is to treat. And we need very clear information to stop treatment. So in that situation, we keep going. We have multiple family conferences. We get social workers, chaplains, anybody else we can to try to get consensus as to next steps. In the extreme situation where there's disagreement, there are ethics committees. Each hospital has an ethics committee. They can consult. And hospitals are developing what they call futility policies now to try to deal with cases. Some hospitals, the ethics committees say treatment should be discontinued. Then the hospital could notify the family that they need to find another facility. But that doesn't really solve the problem, if you know what I mean. It's a very difficult issue, and that's why having those conversations, identifying that power of attorney is so critical. Thanks for the question. So this is, I'll call her Madge. Madge was a woman in her mid-70s who had an aortic aneurysm that was rupturing acutely, big vessel in the abdomen, and she would have died if it burst. So they took her in for emergency surgery and put in a big Teflon graft. And then I get a call from the surgeon about 5 in the afternoon that she's coming down to the ICU, that her blood pressure is low, she's in shock, she's not making any urine, would I please handle it? So this is kind of life in critical care. So we did. We got her blood pressured up and tried to stabilize her. But she was very, very sick. The lungs started failing. She developed adult respiratory distress syndrome. Heart function was marginal. Liver and kidney function were marginal, but she was hanging in there. And this went on for quite a while. Her son was a firefighter. He would come in and say, "Hey, Mom, come on. You're going to make it. Let's go. We're going to go to Puerto Vallarta for a beer." And somehow or other, maybe on some level, she was hearing that. But at about 4 weeks, she developed sepsis with bacteria growing out of her bloodstream. So we had to use big gun antibiotics, remove all her IV lines and replace them. She was still kind of hanging on, really not doing all that well. And then she developed a fungal infection in her bloodstream. So again, antifungal treatment. Son was saying, "Hey, Mom, come on, hang on, hang on." We knew her prognosis was not good, but she did not truly have a terminal disease. She didn't have underlying cancer, underlying severe lung disease or heart disease. She had been a pretty healthy person prior to this rupturing aneurysm. The nurses were wearing out, and I was beginning to question, are we just prolonging her dying, or are we benefiting her? And these are the nuances of what happens as we're trying to make decisions. But anyway, son kept cheering her on, and just almost miraculously at about 7 weeks, blood pressure picked up, the lungs started to clear, she started to become mentally alert. We were able to get the tubes out progressively, and were able to move her out to the medical floor, and eventually she went to rehab in a skilled nursing, and I lost track of her. Now my wife is here, she can verify this. We were with the kids at SeaTac Airport going to Puerto Vallarta on spring break. And this little old lady, I had no idea who she was, said, "There's my doctor, you saved my life," you know. So yeah, we were on the same plane to Puerto Vallarta. And actually we had a beer together down there. So these are the unpredictable parts that we face. On the other hand, there are some people that just don't quit. This is an unfortunate lady I'll call Stella, who had lung cancer that had spread, widely spread. It was stage 4. She had tried chemo. We did some palliative radiation, but she wanted a miracle. She just was unwilling to stop. So she got on a plane, went offshore somewhere south of the border to go to one of these centers where they promised cures and drugs and experimental therapies. But anyway, on the way back to SeaTac, to Seattle, she got acutely ill. So I got a call, kind of a 911 call from SeaTac, that she was in transit to come up to our ICU. And in the ICU, the family was backing her, that she wanted everything done. And it's a very, very difficult, kind of the feudal type of situation. And you know, to get a court-appointed guardian and go against the family would have taken a lot of time and effort, and we thought that, you know, she couldn't hang on too much longer. But she actually died on life support after about 2 more weeks in the intensive care unit. A lot of our expenditures are going in that phase of life for people that just are unable to switch and let go. So that's just so difficult. These are 2 cases that really show kind of some of the ethical issues and dilemmas we have as we talk. I think in American culture, autonomy is so important, the sense of an individual choice and respecting that. However, do no harm, certainly that's it's ingrained in the Hippocratic Oath. And then the concept of beneficence, this paternalistic thing, you know, we're going to do the right thing for you. I was taught in medical school, you don't even tell a patient they have cancer. You whisper it to a family member, and it's all very hush-hush, paternalistic. We didn't talk about dying. So what I'm talking to you about now, I learned from nurses, I learned from social workers, and some colleagues, some older gray-haired colleagues. This, fortunately now, is being widely taught in medicine. And the younger doctors, I think, get this a lot, and some of the older doctors get it, but it wasn't really taught early on. So how about Jim? He was up on a ladder. By the way, you guys over 65, please don't be up there cleaning your gutters. It gets a little dangerous. Not that I followed my own advice necessarily, but Jim was up on the ladder and had a heart attack, and he fell and broke his neck. They didn't know it at the time, but the medics got there, did CPR, did shocks, revived his heart, got him going again, but he had a very high cervical fracture and was totally paralyzed, much like Superman Christopher Reeves was. And his wife had a lot of resources. She adjusted to this. They set up their home with ramps, special electric wheelchair with a ventilator on it because he had to have the breathing apparatus. He couldn't move anything. And he started getting recurrent infections. He was really very unhappy with his lot in life. He just wasn't adjusting to it. And after a couple of hospitalizations and needing total body care, after about a year, he told his wife that he wanted to be taken off the ventilator and allowed to die, which he would if we took him off the ventilator. His wife was appalled by that. She kind of pushed him and coaxed him. We told his wife that it was ethically his call. You know, I can't assault somebody with a medical treatment unless we have their permission. So anyway, he continued on. But during that second year, more problems, and he said, I'm just not a person. I just don't feel like a human. I'm certainly not a man. I just want to be allowed to die. So wife, with support from social service and their chaplain and their good friends, adhered to his wishes. She knew he was so certain that's what he wanted. So we heavily sedated him, took him off the ventilator, and within about 5 minutes he was gone. So this kind of respecting this principle of autonomy, his right to be treated the way he wanted to be treated, we really respected. Now I'm going to make an exception in the second case here. This is Tom. He's a young guy, 45. I consider that quite young. His wife made home canned asparagus, and unfortunately, she didn't do it right. And it's tricky with some of the vegetables, but anyway, he was the only one, fortunately, in the family that ate the asparagus. He got acute botulism poisoning, and that paralyzes you gradually over a matter of hours. So by the time he could get to the hospital and hit the intensive care unit, he was crashing. We had to intubate him, get him on life support. And of course, the wife was devastated. We gave him antitoxin and just kept him going. He had young children. They came in. His wife came in. And he actually did okay at a reasonably benign course, but at about, and we knew if we could keep him going, his outlook was for total recovery if we could keep him without complications for 7 or 8 weeks. And at about the 4th week, he was able to start communicating with us, and he really wanted to die. He wanted to come off that ventilator and to be allowed to die. His wife was horrified by this. We were kind of saying, no way, we can't let you die. But on the other hand, he was making a strong argument, and he wanted an attorney. So a lawyer did come in and talk to family, talk to him as much as he could. And the attorney said, even if I tried to get you a guardian, the guardian's not going to go against the wishes of this young family. So I can't do that for you. So he was stuck. And he did fully recover. Got out of the hospital. I actually saw him back a month or 2 later. And I said, well, Tom, what do you think about all this? What do you think about what we did? And he said, well, obviously, Dr. deMaine, I'm really happy to be alive. But part of me is still really pissed off at you guys. So he was conflicted, So again, there's a lot of nuances in this kind of decision making. Another patient, Bertha, she had severe primary pulmonary hypertension. The arteries in the lung developed a very high pressure, and she was beginning to fail, needing oxygen. There are some drugs that we used, but this really wasn't working for her much, and she was still going downhill. She really qualified quite easily for a lung transplant, but she said, no, I really don't want anything like that. And she wanted to make a last trip to Guam to visit family. We got her oxygen for the plane. She got oxygen in Guam. She sent me a postcard saying, Dr. deMaine, I'm doing just okay. See you when I get back. So I said, well, bring your husband in with you. I want to talk a little bit more about transplant and why you don't want it. But again, she was very clear, and her husband agreed with her wishes that she wanted to just go in a natural way. She said, I'm in the Lord's hands, and that's the way I want to go. I want to die at home. I want my family to be around. So we transferred her into hospice, and I kind of lost track of her care, although the hospice nurses would send me notes periodically on her status. And then one day I got a call from the hospice saying, Bertha would like you to make a home visit. She would love to see you again. So it wasn't a long way from the office. I stopped there around dinner time, knocked on the door, and I heard music and noise, coming from inside the house. And one of the grandkids answered it, and there was food all over the table. There was nice music on, grandkids running around playing games, and there was Bertha in a hospital bed right in the middle of this, with her oxygen going. She had a little morphine that she could use just for comfort. And I sat down and chatted with her a little bit, played doctor. I pulled out my stethoscope and listened to her lungs. And she said, Dr. deMaine, you must be tired. Why don't you go get some food? And she was taking care of me. And, she was just such a remarkable person. I just always remember that kind of sleepy smile on her face. And she died peacefully at home under the care of hospice a few weeks later. But this was her choice. It was our responsibility to respect it. With hospice, the problem with hospice is that a lot of people don't get into it until the last few days. The average length of stay in hospice is like 3 days. So people wait and wait and wait, keep trying things. The hospice benefit needs to change. It needs to allow you to continue some curative therapy while you're transitioning into hospice or learning about hospice. There's even some programs called pre-hospice where you can be introduced to hospice before you actually get into it. So it's a Medicare benefit. A lot of insurance companies offer hospice, and they're a bunch of angels as far as I'm concerned. They really provide total care. They look at the whole person, taking care of your symptoms. You get some volunteer services, a nurse available 24/7. You get added medication benefits, durable medical equipment benefits. So, and the interesting thing, if somebody can get into hospice and get on good care, they actually live longer than predicted. It's a 6-month benefit, but they don't flunk you and kick you out if you live longer than 6 months. I've actually saw some patients get into hospice, they started doing so well, they left hospice for a while, only to get back in later. Palliative care is a new specialty in medicine. They work with hospice, but also work with people that aren't on hospice. The idea of palliative care is to focus on the whole person in a holistic way. You're seeing multiple specialists, you're seeing a kidney specialist and a lung specialist and a heart specialist, but maybe they're not communicating everything, or you really don't know what the big picture is. They come into these complex medical situations and focus on a total care plan. But it shouldn't just be for specialists. The Palliative Care Center for Excellence over at Harborview, it's funded through the Cambia Foundation. They have large grants now. They're training palliative care physicians, but also training primary care physicians, PAs and nurse practitioners in the modern techniques of this total picture, total care, relief of symptoms. So how do we die? Well, this is kind of a typical way to go. Somebody asked a philosopher how he would like to go, and he said, well, when I least expect it. And this idea that we can, be skiing down the fall line of Crystal and go off the cliff, it generally doesn't happen that way. So we tend to have slow decline, periodic crises, and then there's always something at the end that takes us. Classically, it was pneumonia, but now we can use antibiotics. So if somebody's, let's say, on hospice and they get severe urinary infection, then you have to decide, okay, would they really want an antibiotic or not? This is one of the choices. Sometimes with somebody in a nursing home with severe dementia, and if they get an infection at the end, it can be a blessing not to treat them with an antibiotic. On the other hand, if it's a painful infection, maybe the antibiotic would be palliative. So there's nuances in the situation. Woody Allen says, I'm not afraid to die, I just don't want to be there when it happens. So Kate Sewell interviewed me on KUW several years ago, and her first question was, what is a good death? And I've thought a lot about that lately, and it almost sounds like an oxymoron, doesn't it? I would call it a good enough death rather than a good death. But as I mentioned, the things we want are good symptom control, preparation for death, some kind of both spiritual and natural acceptance of the inevitable, completion of certain life goals, maybe a wedding, a graduation, something, anniversary. And I think all of us want some kind of sense of leaving a legacy for others, for our loved ones and family. And then most people would want to be at peace, surrounded by loved ones. And more as we move end-of-life care into the home with good hospice care, this can actually happen. Brittany, I think I'm going to get the pronunciation right, Menard, I think is correct. Anyway, she is kind of the face of death with dignity, which I think Washington stands at the forefront nationally, along with Oregon and now California. But Brittany lived in a state where they did not have a death with dignity law. She had brain cancer, it was spreading, they tried treatment, that failed. She was having uncontrolled seizures, severe headaches, and her quality of life severely deteriorated. She was supported by her husband in this decision. You can imagine how difficult that might be. But she established residence in Oregon in order that she could have medical assistance with her choice. And she went public with this. There are YouTube videos available where she is talking about how she made that choice. And I don't know all the details behind it, but I would imagine this had quite an impact in California, where the death with dignity law was passed in our largest state and signed into law by Jerry Brown. So in Washington State right now, about 1 in 500 deaths are related to the death with dignity law. Oregon has more mature statistics, so I'll just show this slide briefly. In the dark blue are prescriptions written. It starts in 1998, and the data is up through 2015. So there is a gradual use. We don't know where this plateau will be. I think their frequency is a little higher than Washington State. But what's interesting is the prescriptions written are higher than the actual deaths. And this means some people want to have the prescription. Well, number one, they want to have the right to have the prescription. Then they obtain it, and then they make the decision. So it is a very, very personal decision. I know in this neighborhood there have been some. I know there's been one at Horizon House, and I know there's been at least one in Skyline. So retirement communities, the more progressive ones anyway, are willing to abide by honoring this law and this choice. So what is VSET? If anybody was here listening to Diane Ream's talk, you know about it. And also there's a wonderful TEDx talk from Bellingham by Phyllis Schachter, whose husband was entering into dementia, but still rational enough to say, I want to stop eating and I want to stop drinking. And he did not qualify for death with dignity because he was not terminal within 6 months, so he had to choose another route. It sounds like this might be a very, very difficult thing to do, and it's certainly hard on the spouse and somewhat hard on the individual going through this, but with medications, some sedation, good management of symptoms, it can be done and has been done. And Diane Ream went very public about this in her book called My Own Way and Phyllis Schachter's video. So probably happens a lot more in nursing homes than we know. I think in a way maybe my dad did it at 94. Maybe he decided it's enough. I'm just going to quit eating, die the old-fashioned way. So we do have a lot of choices that face us. Right in this neighborhood, we got Harborview, Swedish, Virginia Mason, all these high-tech people. 911 is right down the street. So we can choose to have full treatment, and that's fine. You know, you have to get, at some age, you're going to decide you don't. Or we can have some limited treatments, maybe no ventilator or CPR, but we would want full care otherwise. I had one fellow came into my office and said, hey, Dr. deMaine, listen, at the end, no tubes. And I said, well, Harmon, what if you got a pneumonia, because he had pretty bad emphysema, and I gave you antibiotics, and you weren't doing very well, but I knew if I put you on a ventilator, breathing machine, that we could kind of keep you going and probably get you off and back to the way you are within 2 or 3 weeks. And he said, well, of course I'd want that. So you got to be a little careful when you say, don't do anything. And particularly for hospice patients, comfort measures are the main line of treatment. And my dad was reluctant to sign any advance directive. He said they're just going to put me over in a corner and they're not going to do anything. He was a retired GP. But so he probably knew something that I didn't know. But in this era, just because we're not going to do high-tech intervention doesn't mean we don't care. You know, the secret of caring for a patient is to care for the patient. It's Francis Peabody, not me. But the comfort measures, some excellent comfort measures are available and probably underutilized. So how about CPR? The survival rate, if you read it on television, look at television and ER, people will have their CPR and get up and walk out of the hospital. So it's way too high. For the average overall population, it's around 5 to 15% of us will make it to discharge from the hospital. For the frail elderly, and I don't know exactly how to define that, but you get into a point probably up in your 80s or 90s when you say, I've lived a full life, I really don't want that. And actually the outcome of CPR as we age starts to diminish. It's not zero. Even in their 90s, some people have survived CPR. Advanced chronic disease, if you have a cancer and stage heart disease, the idea of doing CPR is really futile, and the nurses hated to do it. They called it medical last rites, but every once in a while, it was almost a performance for the family, and something they felt, it caused a lot of moral dilemma, and there's articles written about that. If you have a shockable rhythm, let's say you're a 60-year-old and you go down and they come and do CPR and they find there's what they call a shockable rhythm, an actual dynamic rhythm to the heart, but it's not pumping adequately. If they shock that, and with modern techniques of cooling the body down, temperature down, the best survival in the country. Morley Safer came out here for 60 minutes way back when in the 60s when this all started and said then, and I think it's still true now, that Seattle's the best place in the country to have a heart attack. Now you can, I don't know, if people here familiar with Smart 911? It's at smart911.com. You can register online. You can enter into the 911 database your health information, saying I'm allergic to bees or a certain antibiotic. You can state whatever you want to put in there, your medications. You even put in your wishes if you want, although you can't actually add forms into this site. But you can verify your phone so that when you call 911 from that phone, that's the first screen that will come up to the dispatcher. It doesn't have GPS built into it, but I think we'll have that one of these days. But it would have your home address, could have your picture, whatever you want to put in there. And it's available in all the zip codes in King County. It's not available statewide yet, but it's being funded moving out and around the country. So it's one more way of having your health information available. Few of you raised your hands about the POLST form. On the handout table back there, I do have some POLST forms if you want to pick one up. It's not the kind of form that you would fill out and just mail into your doctor. This requires a very heart-to-heart discussion with your medical providers about what your wishes are. Generally, it's applicable to people that are really sure they don't want CPR, applicable to people on hospice or are pretty sure they're in their last year of life, or they're very frail elderly. This form's bright green, so 911 can find it when they arrive. In hospice, it's commonly at the foot of the bed. Where I live, we have a lot of active seniors that don't want to look at their POLST form every day, so we store it inside the kitchen sink door in a folder. But there are a variety of ways of finding this, knowing where it is. I had a patient out on Mercer Island that had end-stage disease. The family was really worried because she wouldn't have anybody live with her. She they posted her POLST form all over the house and walked a copy down to the Mercer Island Fire Department and put a realtor lock on her front door so they wouldn't have to bang it down. So there are ways of being prepared. So this also gives other desired treatments. Again, it's mostly for hospice, people that don't want resuscitation, frail elderly. It's signed, it's a unique form, it's actual medical orders. This is honored by every medical institution in the state. It's transportable from home to hospital, from hospital to skilled nursing. It is actual, actionable medical orders. 911 loves this, because if they come and see that it says, there's a checkbox on there that says, do not resuscitate, they'll know right away they don't have to do that, and then they pay attention, transport to the hospital, whatever, is on there, the kind of treatments you would want. So can we find a time for these conversations? I think by your coming here, you're probably making that affirmative. But what my hopes are, talking to your loved ones, make an appointment to your medical providers, talk to them, fill out a power of attorney for health care. On the handout sheet, I gave you an essay that a patient handed to me about what their wishes were. That can be attached to your directives. The more information you can give to your medical team, the better the decisions are going to be. And do a POLST form if frail. Now I'm going to use a little high tech here and show you this video I have.
Just gonna stand there and watch me burn. End of life and all my wishes go unheard. They just prolong me and don't ask why. But it's not right, because this ain't the way to die. This ain't the way to die.
I can't tell you what I really want. You can only guess what it feels like. And right now it's a steel knife in my windpipe. I can't breathe, but you still fight, cause you can fight. Long as the wrong's done right, protocol's tight. High off of drugs, try to sedate. I'm like a pin cushion, I hate it, the more I suffer, I suffocate. Right before I'm about to die, you resuscitate me. You think you've saved me, and I hate it. Wait, let me go, I'm leaving you. No, I ain't. Tube is out, you put it right back. Here we go again. It's so insane, cause though you think it's good, I'm so in pain. I'm more machine than man now, I'm Anna Kane. And no advance directive, I feel so ashamed. And crap, who's that nurse? I don't even know a name. You lay hands on me to prolong my life again. I guess that you must think that this is living.
Just gonna stand there and watch me burn. End of life and all my wishes go unheard. They just prolong me and don't ask why. It's my right to choose the way that I should die. The way that I should die.
Z-Dog MD.
The way that I should die.
This ain't easy. Get the family. You ever love somebody so much you can barely see when you with them, that they lay sick and dying, but you just don't wanna let them be at peace, cause you miss them already, but they ain't gone. Beep beep, the ventilator alarms. I swore I'd never harm them, never do nothing to hurt them. Hippocratic oath, dream them, not know, so right now I'm forced just to torture them. They push full code, no one knows what his wishes were. His sister heard him say once, I don't wanna be a vegetable. But no one agrees in the family. The caregiver Kate wants some comfort care, but Aunt Claire lives so far away that her guilt eats her like a cancer, so she answers, wait, I think you'll wake. Ma'am, you ain't even in the state. Palliate, relieve pain, get him home, explain. Critical care, just hypocritical when it's so insane. But they insist I shock his heart again, so I persist. I guess that's why they say that love is pain.
Just gonna stand there and watch me burn. End of life and all my wishes go unheard. They just prolong me and don't ask why. It's my right to choose the way that I should die. The way that I should die. The way that I should die.
Yeah, the idea, just a plea again to have the conversation and talk to your loved ones. So I hope that isn't too much of a downer to end this on. It's so unusual to kind of have a rap video about dying in the ICU. So I'll open it up at this point. Yeah, I'll get to you in a second. Yeah. If you could talk kind of loud, and I'll try to repeat the question.
I didn't understand the definition of a living will, and if it's the same as the POLST.
No. A living will, I didn't go into it much because, quite honestly, it doesn't help all that much. It is, if you go on the state website, you'll find two advance directives. One is the living will. This is one, it's kind of a statement of values, saying if I'm terminally ill, expected to die in a reasonable period of time by two physicians, I would or wouldn't want CPR, life support intervention, and then you can check whether you would or wouldn't want tube feeding. But at the bedside or 911 call, you can take that as a statement of wishes, but it's usually a lot more nuanced than that. That's why I said, go ahead and fill out the living will. And by the way, Compassionate Choices has the best document as far as I'm concerned.
End of Life Washington.
Excuse me. Formerly Compassion Choices, now called End of Life Washington. They have a downloadable form, and it has values, it has living will, it has power of attorney, and it's by far the most complete document. So if you're going to go for one to complete, I'd certainly do that.
I still don't understand its difference with the POLST.
Okay, the POLST form just came out maybe 15 years ago, and it is actual standing medical orders. It's signed by you and your doctor after a heart-to-heart discussion about what you would or wouldn't want. This is bright green, so it's what I call a 911 form. So when they arrive, they'll know what you want. And it's actual, the other ones aren't medical orders, they're wishes. And
you mentioned that the suggestion is that that's most appropriate when someone is frail.
right.
And really
The POLST is really hard to know, in advance. It's not true. It's not an actual advance directive that when I'm 50, I can fill this out, that I don't want this stuff. So it's actually when your life gets to the point where you say, gosh, I've had a full life and I don't really want all this stuff and shocks and wind up in the ICU. I'm just happy to go in a more comfortable way. Certainly cancer patients in advance, the POLST is almost universally used in hospice patients. And I have some of those bright green forms back there if you want to pick one up. But the doctor's office or hospitals have them.
it's not one you have just in case the airplane you're on crashes or...
No, because it's not a what if form, it's an actual now form. Yeah.
Do people wear bracelets and necklaces as well?
Okay, but I'll go into that because it goes, as far as I know, Washington state law is silent about bracelets. There's some fancier new ones that actually there's a necklace or a tab that has a USB that or even a scannable. They can look up your documents that way. I've asked Leonard Cobb, who started the whole 911 program, I said, if I had a bracelet on that said, do not resuscitate, in nice big bold letters, and it was attached to my wrist, do you think they would? He said, well, they might do that, but we don't have clear law. In some states, it's actual law. If you have it on, they will respect it. I think we need to work with the legislature to move that one forward. I'm sorry, you had a question over here.
Sort of two questions. When somebody's on a ventilator, it's hard to know how much they're suffering, right? How much are people suffering in that situation?
Well, the question is, how much are you suffering when you're on a ventilator? It kind of depends how awake you are. If you're awake, it's pretty intolerable, or you're confused because you try to reach up and pull the tube out naturally, and so sometimes you have to be restrained and sedated, so it's no fun. If you have to have the tube down for any length of time, then they'll actually do a tracheotomy and attach the ventilator right here to your neck, and that, believe it or not, is a lot more comfortable. So it is hard to know how much somebody is suffering, and as far as I'm concerned, when somebody's on a respirator, they should be in a twilight zone with medications, and I think the nurses, ICU nurses, are really attuned to that. So thanks, good question. Yes?
How transferable are these forms between states?
The question is, are those forms transferable between state? And each state has its own, all medical law and procedures are by state. The forms don't differ tremendously. It's a good idea to carry them with you if you travel. But if you're going to live 6 months down in California and 6 months here, I'd get both sets of forms filled out. If I get a POLST form from Oregon, for example, and somebody up here, that's the best I have to go by as a physician. So these forms will have some credibility for the doctor at the bedside because that's the most information we do have. So you hope it gets respected, but with our current medical system being all state by state, we don't have uniform forms.
Is there a site to go to where you can see which state requires which particular form?
Yeah, you can go on the POLST website will show you all of those states, and then if you just type in advanced directives, you can download the advanced directives for each state. Yeah.
They also have wallet cards, specifically through Gunderson and Respecting Choices. They have wallet cards that you can fill out and carry with you in your wallet that say where your advanced directive and POLST forms are stored
Right.
for your physician in your hospital.
Yeah, I think it's a good idea if you do have those forms to have some other, either a bracelet or a wallet card, because that's usually where they'll start looking for your insurance, if nothing else, to find out, where you're going to go. Unfortunately, the actual POLST is so large. Copies are valid, by the way, but it's a real problem, I feel, to have the POLST form be available real time, unless you're a hospice patient, pretty confined, and the form is right there. But if you're ambulatory, it's not so easy, and some people get CPR. See, it's funny, it's a society, we're all signed up for CPR. We're allowing a stranger to come and start chest compressions, and that's okay. There's Good Samaritan laws. You've got one of those cards.
And
Yeah.
the life does have a form that is POLST color.
Right.
But do caregivers actually go through your billfold, or do they just, what do you think?
Well, I think 911 responders try to find, they look for your cards, what hospital organization, et cetera. I kind of like the medallion. Some people don't want to wear a bracelet that advertises the DNR, but you can wear a medallion, and some of the medallions, like I saw one from down in California, it said, "Do not resuscitate," and then had all the, my POLST form is at whatever situation, it was all engraved on the medallion. So it kind of depends. We don't have good best practices or standardization. I still think having people that know you and loved ones that are strong advocates are the most important thing. You just can't rely on check boxes and forms. And there's some evidence that these sometimes don't even get looked at or adhered to. So it's a little scary. Yes?
Could you explain if you have met the criteria to have a prescription under the Death with Dignity law? Does that have to, you do have to be in a way you can self-administer that, or can your loved ones do that, or do you have to have like a nurse do that? We have Death with Dignity folks here, but my understanding is under Washington state law, you have to be able to self-administer the drug. So if somebody's totally paralyzed, unless they could have some kind of apparatus that they could maneuver, it's a protection for disabled people. Of course, in Europe and some of the European countries like Holland and Belgium, they're much more liberal and allow lethal injections, but we've not gone that route. Canada, on the other hand, is in limbo. They declared unlawful restriction. In other words, people have a right to die, but they haven't passed laws defining that yet. And some people feel that it should be liberalized and allow another person to administer the dose. But the protections were built so strongly to prevent abuse. And so far, really, there's been almost no situations where abuse has been reported. So, yes, sir.
I understand that some of the Roman Catholic hospital groups have policies that are different from state law, and that in some cases prohibit professional staff from complying with things like death with dignity. And I'm concerned that those hospitals are merging with secular hospitals, and pretty soon it'll be hard to find an institution that will actually respect some state law provisions like this.
Yeah,
Any advice about that?
Yeah, the question is about whether religious-oriented hospitals set their own criteria and kind of prohibit people from carrying out what's passed by law. There's been a lot of concern at group health where I work because we tend to use Catholic hospitals, you know, in Bellingham and Olympia and now Swedish, which is owned by Providence. In speaking to the doctors there, they feel there's absolutely no interference in the intensive care unit, the kind of things I described, removing people from ventilators, allowing people to die. I think probably where they would draw the line, I don't know this for sure, what their policy is to have a death with dignity occur in the hospital. But that would be rare. Do you have any data, the folks here from?
I know that Providence doesn't allow voluntary stopping eating and drinking in Providence Hospice.
That what, I'm sorry?
Providence Hospice will not take someone that wants to voluntarily stop eating and drinking.
Right. Some of the hospice people almost feel it's a defeat of their mission to enable a transfer, a seamless transfer into the death with dignity mode. And you can understand where they're coming from. I think if we are going to invoke death with dignity for any individual, we have to make sure that they've had the best palliative care, hospice care, et cetera. They're not forced into that choice because of insurance issues or available medical care issues. Almost all the actual ingestion of the barbiturate, which is the most common use, death with dignity, occurs in the home or a home-like environment in a nursing unit, but not in an acute care hospital. Hardly anybody spends more than 3 days in a hospital now. You know, they get you out quite rapidly.
One quick follow-up to that.
Yeah, sure.
I noticed that the Compassion and Choices End-of-Life Washington form does have a paragraph that authorizes your medical care assistant to transfer you to a different hospital or to a different institution if there is a problem of that kind,
Right.
at a religious affiliated hospital. So
That's an important right that you have is to have an advocate that can work with the team to get you to get you to the care that you want and deserve. Yeah, good point. Yes, sir.
You spoke about aggressive medical care, the person that had the full body scan, and the artificial ventilation and nutrients, and the extending of life, and also providing a hospice. Who pays for that?
For which? For
Medical costs.
we do. Yeah, the question is who pays for the extended care in the ICU and who pays for hospice. Hospice actually is not all that expensive because hospice occurs in the home by and large. And then you do have added services there, and it actually keeps people out of the hospital, which is much, much more expensive. So the tragic ones to me are the people that continue to get aggressive chemotherapy, even though it makes them deathly ill. Somebody, the oncologist said, well, we do have one more drug. And this is what Atul Gawande points out. Your specialist can always think of one more thing to do. And the more compassionate ones will say, and I think a good question for the doctor is, if it was somebody in your family, what would you be recommending to them? And make it more personal. One more point.
Many of us are on the Medicare program.
Sure.
And so that is taken care of by government and our taxes and our problem because of the judgment of the hospital of prolonging life rather than letting.
Well, it's not a judgment of the hospital. When I talk to critical care doctors, they say it's the families that won't let go. And sometimes it is the doctors that won't let go. I don't think the hospitals tell the doctors, you got to keep them in longer because we need to generate more revenue. I haven't heard that. But yeah, it's all over the place. Sometimes the individual patient expects the miracle. Sometimes the family's arguing and can't come to a consensus. But it's better. It's gotten better over time. But you know, we still have a long way to go. I'm probably keeping people too long now. Back there, please. Oh.
I have a question about Mr. Ladder and Mr. Asparagus.
Okay.
Mr. Ladder was on a ventilator, demanded to be taken off, his wishes could not be ignored. So he was taken off the ventilator and allowed to die. Mr. Asparagus was on the ventilator, demanded to be taken off the ventilator, his wishes were totally ignored. What is the difference here?
The difference is the ethical principle of beneficence. We use that to trump autonomy, and also we invoke do not. We thought we would harm him more by letting him die than what we were doing, keeping him alive. This is the problem with ethics. We have conflicting ethical principles, and even he was conflicted afterward about what the right choice would be. So we opted, I presented this case to Al Johnson at the University of Washington, who runs the ethics. He said, well, that's interesting. Every once in a while there is an exception. So I just pointed out how nuanced some of these decisions are and how difficult when you have it was very difficult. Good point. Yes?
If I reference the cost of all of this in my forms, and I say something like, if I'm burning through Savannah's college fund, let me go. I mean, they're just going to avoid that immediately, right?
Mm-hmm. Yeah, I have patients to say, I really don't wish to be a burden in any way. So they have to care for me 24/7, that they're just burning through all the funds that would go to much better use. Write those out in an essay and attach them to your well, the POLST form wouldn't have any. You know, that's just a set of orders. So you need your power of attorney, and then you need a statement, the living will, but you can attach values and thoughts and essays. The more information you have out there, the better the decisions are going to be. Yeah. Yes, somebody over here.
I wanted to say I really appreciated you talking about voluntary stop eating and drinking. I know that in the past, it used to happen probably a lot more because we weren't as medicalized as we are now.
Right.
And I think it's something that everyone who comes to a meeting like this should know about. So thank you.
Yeah, thanks. And if you do get a chance, if none of you have seen it, Phyllis Schachter's video, I have the link on the handout sheet back there. And also I have some stuff from People's Memorial, which is a wonderful co-op from End of Life Washington, and some smart911.com handouts, so help yourself to those. Okay, let me go in the back over here. Yes?
Hi, I just want to apologize for being at the beginning of the post-war baby tsunami. Getting all my children and grandchildren, you know. Anyway, thanks for attending because it's a real fact. And one question is, you know, I don't want to be the guy that doesn't recognize my family.
Right.
Or them see a rumor of recognition. I don't want to be the guy that's making a fool of myself during the time.
Right.
How can I protect myself? It's like I want to go to Fantasy Island someplace and just see these things quite a few.
Well, the question, it really gets around mental capacities rapidly declining, and it's a fear we all have. We're all going to live longer. We get up into our 90s, about a third of us are going to have some degree of dementia, so that's a real fear. And there's no obvious solution to that. I think there will be some breakthrough prevention and treatment modalities. I don't know how long that will take. It's going to be wonderful for big pharma, but probably very expensive for the rest of us. The stopping eating and drinking the way voluntarily, that's the way Phyllis Schachter's husband decided. He was a brilliant engineer, but he just saw himself declining, and he decided he didn't want to go there. Very tough choice. And there's one in front of you, yeah.
Well, my question is around this tsunami. Do you feel like, the hospitals or the medical system is prepared for the onslaught that's coming? And how can we get prepared? How do we engage people in having this conversation? We've got a handful here, but boomers are a lot.
Yeah, the question is, as the boomers, thank you boomers, go into this aging process, are we prepared as a society? And I think we're still way behind the curve, and people don't have enough savings. The Medicare system is going to be difficult. A lot of people think long-term care insurance is covered, or long-term care is covered by Medicare, and it's not. So without long-term care insurance, you have to spend down all your funds to get onto Medicaid. And I work as an ombudsman, volunteer ombudsman at a nearby nursing facility, and it's really sad, even for the folks that are there now. So there's 1,300 adult family homes in King County alone. We're housing some of the elderly. They're out of sight, out of mind, but they're really there. And the Medicaid system is very much stressed, and they're cutting back some of the benefits. So politicians are aware of this. People don't want to pay taxes, so we're going to have a dilemma as we age, for sure. Yes, sir.
Do you still come across situations where people are spending years on a ventilator and in a coma because the system just can't make a decision, or is that kind of going past that?
Well, I have a friend at Virginia Mason that would have somebody on a ventilator. The question is, what happens with really prolonged life support? I remember we had a group health central that stayed on the ventilator for a year because the family would keep calling the Seattle Times and threatening to sue, and it was really very difficult situation. There is a hospital in South King County called Regional, which is a chronic ICU. So if you have a patient on a ventilator, you're having trouble weaning them off the ventilator, it looks like a chronic situation, family doesn't want to let go, they're transferred down there. I don't know what their average length of stay is, but almost everybody is on some kind of life support there, and it's basically a very expensive chronic intensive care unit. And one doctor sarcastically said, that's where I send my patients when I don't want to get sued. So yeah, some of this does go on. We aren't very empowered to go up to the bedside and say, Medicare's not going to pay for you anymore, or what we're doing just doesn't make sense. The ethics committee has recommended we pull the plug. It's very hard to do. Yes.
Well, and that statement versus what you said, if somebody wants to voluntarily stop eating and drinking in a hospice care unit, they can't do that right now very easily.
They can't?
They can't do that very easily right now.
I missed do what? I'm sorry.
Voluntarily stop eating and drinking under hospice care in a hospice care facility. If you want to do voluntary stop eating and drinking, you need to do it in the privacy of a home.
Yeah, and the vast majority of hospice care is in the home. There are a few inpatient hospital beds in the area for people to go in when the family just can't handle it at the end, and they go in for some respite period while the family regathers. But one thing I didn't mention in this is the stress on caregivers. It's just huge. And we need to care for the caregivers and nurture them, and hospice is oriented toward training caregivers and supporting caregivers as well. Yes?
The durable healthcare power of attorney, is that something that stands even if, members of the family can't agree? It trumps that?
Yes, the question is, if you have durable power of attorney and your brothers and sisters disagree, sure, you talk to them, bring them into the conversation, even get them on the phone, but they need to understand that you have the final decision making. Yeah. A social worker and I wrote an article, it's called Shared Decision Making in the Intensive Care Unit. And the way I would try to deal with that, if we had, I call Aunt Minnie in Minneapolis, who we knew was going to throw a wrench into the whole decision, we would get her on the phone for each conference we had, so they felt included and then began to understand what was going on. So, yeah.
If you choose to stop drinking and eating, will they give you some drugs that make that doable?
Yeah, the question is, if you stop eating and drinking, can you be given drugs to help you? And the answer is yes. You need a family physician or internist, a provider that is really willing to give you sedative drugs to help. They're not knocking you out, but they're just making you more comfortable. And there's some very good ones. You know, some of the narcotics can help. Some of the Valium type drugs, the benzodiazepines can help for sure. I think that up at Phyllis Schachter's husband, they really found a nice young woman internist that could really help them and work with them one-on-one. They have to find the right doctor that's really going to work with you. Well, thank you very much. I think that's the question.